Very good evening to all. This is Dr. Raghu once again back through the Medusane channel. And today we are very happy to have the first session of this year, especially for the 2020 batch who are going to be writing your university exam sooner by March. So today I welcome Dr. Prithiviraj sir. We are thrilled to introduce Dr. Prithiviraj, Junior Resident, Department of Pediatrics from Burdwan Medical College. Having conducted numerous insightful classes in the past, he now joins with us for the final year lecture series for the 2020 batch. Today, he will be shedding lights on two crucial topics. One is the fetal circulation, which we actually read in the anatomy but tend to forget easily, and the approach to congenital heart disease. Let's make this session the most useful and deepen our understanding of these important concepts. A big thank you for Dr. Prithiviraj sir for his dedication and for educating and inspiring the young medical minds. Thank you, sir, and now the session is yours.
Good afternoon to one and all. Thank you, Raghunandan, for giving an opportunity to for this classes. Uh, I am taking since 2023. I am been attached to this medicine, and I have taken about around 10 or 12 classes. And so from this year, we will be having a regular classes or in the feed in the pediatrics. So this year we are going to start with the topic of cardiology. So these classes are mainly for the revision purpose and also to understand the basics of the topics so that it will be very easy to remember and also to reproduce in your examination. It's mainly the purpose of these classes is for your revision and also to know the concept behind each and every topic which you are reading uh, in this subject of pediatrics, and also to make your concept clear so that you can easily remember and write that in your exam, reproduce in your examination, and also to get good mark. So let's begin the topic proper. So today we will be talking on in upcoming sessions for this month and also in the next month in February, we will be touching on cardiology and main important topics which will be repeatedly asked in the university exam for both UG as well as postgraduate. So the content of our session for today content is only two. First two topic will be discussed in detail. That is fetal circulation and how fetal circulation is the transition occur from a fetal to a neonatal and approach to congenital heart disease in neonate. While the other other topic which has been given uh, in this slide will be taken in the upcoming sessions. So, fetal to neonatal transition. This is one of the most important thing. So, in utero, from fifth interuterine life, that is from your 38th day of the life, your heart start to beat. So, the heart is a miniature, and it will be the miniature structure, and it start to beat. But the okay to beat. So what actually happens from that fifth uterine life till the complete gestation, like up to 40 weeks of gestation, the multiple things that happen to mature in a circulation so that the baby can adapt to the extra uterine life. That is once the baby born uh, to this world, it has to adapt to that particular neonatal or as adult circulation. How that changes occur and what are the phenomenology that the fetus, the neonate will follow so that it can adapt from in utero to ex utero environment. So first, you should know how the fetal circulation is different from the adult circulation. The mainly these three things is the one. One is your parallel arrangement of two main. Okay. Sorry. So the okay, I guess it's visible. I guess I think because of all.
No, sir, not visible.
இருங்க. Okay, wait. Okay. Yes,
Yes, sir.
it's again visible. Okay. Okay. So how the fetal circulation is different from the neonatal circulation? That is the adult circulation. The one thing is when you see this is the circulation which is seen in the adult, right? So the blood has to pass to all the four chamber and to the lungs, and then for first all the four chamber, and it returns to the point where it started. Like for example, from point A, it has to pass to this R1, R2, R3, and point B, and again this A. So it has to circulate through all the pathway of your circulatory system so that it will complete one cycle. But in our body, so our blood from the deoxygenated blood comes from all other parts of the body via inferior vena cava from the lower part and superior vena cava from the upper part. It ends into your right atrium, right ventricle to your pulmonary artery to your lungs. Then it goes and turn around and it comes to your, it get oxygenated and comes to the left atrium, then left ventricle, and then to aorta. And again, this cycle will continue. So this circulation, what happened in adult, in the children, is the series circulation. That is known as series. So it has to pass through each and every component. It has to pass through the each and every component. That is, this are all this component has to pass. But what happened in fetus? The thing which is happening in fetus is they have a parallel circulation. That is, it can bypass some part so that the main the thing which the fetus has to the main functions of the fetus would be like what we see in adult. Every organ is important, but in utero, fetus has to grow particular organ which is very important for the survival. So that's the reason why the head of the child is larger compared to the other part when you see the child after birth. The reason is the brain has to require most of the oxygenated blood to reach it so that it can have a proper nutrition and oxygen, so it has a proper growth, and maximum growth occurs of your brain within the first 2 years in utero. So for that to occur, it requires more oxygen. For that, it has to receive maximum oxygen content blood. So how the body, the fetus do that? That is the thing. By doing this parallel arrangement of two main arterial system and the respective ventricle. So they will. So that means the blood will not pass through all the components of your circulatory system. It may bypass some of this component so that the oxygenated blood will reach the brain and other part which is very vital for the survival of the fetus in utero, while the remaining part will receive some get adjustment. It will get a mixture of oxygenated and deoxygenated blood, but maximum oxygenated blood will reach the brain and the heart, which is very vital for the survival of the fetus in utero. That is a parallel arrangement. Second is the in adult and children, it's your lung which is the main site of oxygenation and ventilation. Whereas in fetus, everyone knows placenta is the site of gas exchange. And in adult, we don't have any shunt like ASD, that is foramen ovale, ductus arteriosus, ductus venosus. But this is present in the fetal circulation. That is the presence of shunt. So these are the three main features that differentiate an adult circulation from the fetal circulation. Why these are important? Because, as I said, for fetus to survive and also the major growth of your brain is very important. So, because first 2 years of life, your brain achieve 98% of its growth. So, for the proper development and growth of your brain and also proper functioning of your heart, they require the maximum oxygenated blood. While the other organ, though they grow, though they develop in utero, but they don't work. The maximum work will occur only after the maximum work and function will start only after the baby is born to this world. Before that, they just be in a dormant state. So for that, they require a minimum energy. So maximum energy expenditure will occur in your brain and heart. So For that, this blood has to be circulated to that particular organ. For that, this parallel circulation and shunting of blood is very important. So this is the diagrammatic representation of the fetal circulation. So from placenta, all the oxygenated blood will start. It will go to the umbilical vein. From umbilical vein, the blood get bypassed. 50% of this blood will bypass into your 50% of blood will bypass the oxygenated blood from UVC umbilical vein. It will 50% will bypass through ductus venosus, while the 50% will enter. This is about the oxygenated blood. Of blood will enter the left portal vein. Now, this left portal vein and ductus venosus and, and this left portal vein will enter to the left hepatic vein, and then they come to the UVC. But the UVC, when you see the two UVC, you have this shunting. This they have left side, left and right. So the oxygenated blood, okay, this is left side. This oxygenated blood will be here in the left side. So left side will contain the oxygenated blood that arises from the UVC. 50% gets shunted by your ductus venosus and 50% enters the hepatic circulation via left portal vein and left hepatic one. And it enters the left side of your IVC. But you also know the deoxygenated blood from the lower part of the body, from abdomen, is also carried by the IVC. But this deoxygenated blood will enter the IVC or along the right side of the IVC from your right hepatic vein. The right hepatic vein will carry the deoxygenated blood from the rest of the body, from the lower part of the body to the right side of the IVC. This kind of demarcation of oxygenated and deoxygenated blood is very important because, as I said, there are two major vital organs in your body in utero, which is required for maximum growth and development that has to occur your heart and your brain. So, for that, this uh, demarcation of this blood streaming of this blood should be demarcated so that the oxygenated blood would reaches the major organs, that is the brain and heart, for its proper function. That is very required for the survival of the fetus in utero. So the right side will have all the deoxygenated blood. And this process occurs before right atrium. So first is before right atrium in at IVC, what happened? I already said oxygenated blood, 50% shunted through ductus venosus, 50% enters the hepatic circulation via your left portal vein and left hepatic vein, and this enters the IVC along the left side. Whereas the deoxygenated blood from the rest of part of the body via the hepatic vein enters the right hepatic vein into the right side of the IVC. So IVC is divided into right and left with the help of right and left, where the deoxygenated blood is in the right side and the oxygenated blood in left side. Why the demarcation is important? I already told you. Now it has to enter the right atrium. So what happens at the right atrium? In right atrium, not only the right atrium receives the blood from the IVC, it has to receive blood from other part, like so upper part of the body, like upper chest, upper arms, as well as the head and neck from brain via superior vena cava. And also the coronary circulation, deoxygenated blood will also enter your right atrium via the coronary sinus. So you are going to have deoxygenated blood from three sides: right side of the IVC, superior vena cava, and coronary sinus. So how come your right atrium will make arrangement so that your the deoxygenated blood, which is on the left side of your IVC, to go to the brain and the heart without getting mixing with all these three area of deoxygenated blood, from the deoxygenated blood that arises from this three area that comes via a three channel. How come your right atrium managed to do so? It is with the help of the shunt known as patent foramen oval, that is PFO. This PFO, foramen oval, not patent, sorry, foramen oval. So now this foramen oval is the channel via which the right atrium will streamline the oxygenated blood from the left side of the IVC into the left atrium, from left atrium to left ventricle. From left ventricle, this blood goes to the arch of aorta, and then from the brachiocephalic trunk, it goes to the brain. So this process of thing happening where it is streamlining the oxygenated and deoxygenated blood to the respective chamber so that the oxygenated blood will reach the brain properly. So this is known as streamlining of blood. So that is four streamline we will be seeing. So already I discussed this saturation. What is happening? We already discussed in the this slide. So about this four streamline, which I already told, this is the thing. So normally what happen, right? So see, so at right atrium, you have to four streamline has to happen, right? So what happening? You are saying this is the right atrium. Okay. So right atrium receives blood from your coronary sinus. This is from IVC. Sorry. Okay. So what happened? Now see. So coronary blood, the right atrium receives blood from four streams. One is your IVC, right? Then SVC from coronary sinus to treat it. Now what happened? As I already said, the IVC has two components, left side and right side. This left side will carry the oxygenated blood. That is one third. While the two-third is carries your deoxygenated blood on the right side. Now what happened? This the left side, which is an oxygenated blood, this oxygenated blood is given as A1. This streamline directly into the left atrium with the help of the foramen oval. This is foramen oval, and this enters the left atrium from left ventricle into the left ventricle. So this is the streamline. This is known as A1, and A1 corresponds to the oxygenated blood via your foramen oval from right atrium into left atrium, then to left ventricle to the left aorta to the brain. And what about the two-third of the right side of the IVCs contain deoxygenated blood? Now this will enter into the right atrium and right ventricle. So this is the deoxygenated blood that is coming from your IVC and enters the right atrium and enters the right ventricle. Whereas the SVC will carry what desaturated blood from the upper part of the body, and it will also enter the right ventricle. Whereas the coronary sinus will carry 25% of desaturated blood from your coronary circulation into the right atrium, which also get entered the right ventricle. So this kind of traffic, right? So who is that policeman who is making all this to work in a proper way? Like this right atrium, the oxygenated blood has to enter only the left atrium, not into the left atrium, bypassing the right atrium. How on the deoxygenated blood from the IVC, SVC, and also from coronary sinus to enter the right ventricle via right atrium. Who is the one which structure in the right atrium helps to do so? That is your eustachian wall. So this is the eustachian wall, right? This eustachian wall. So this eustachian wall is the one which act as a traffic man in the right atrium to divert the blood in the respective chamber. The oxygenated blood into the left atrium and deoxygenated blood into the right atrium into the right ventricle. So with the help of this eustachian wall, the location of the eustachian wall, the blood get diverted to the respective chambers. So To brief, four streamline at the level of right atrium. So one is A1, which is I said this is the oxygenated blood from the left side of the IVC will enter the left enter the foramen oval into left atrium, then into left ventricle, then it goes to the arch of aorta, arch of aorta, then to the brachiocephalic trunk and goes to the brain. This is A1. So which is already I told. This is the A1. This is A1. What about A2? A2 is the same deoxygenated blood, right? This is the deoxygenated blood. So A2 is the deoxygenated blood. Now A2 is deoxygenated blood from the lower part of the body in the right side of the IVC goes to the right atrium and then right ventricle. And atrium, whatever the SP. Okay, wait. What this is A3. A3 is here. The blood. Oh, no, this color is not visible. A3 is the blood. That is the deoxygenated blood from the right atrium. Sorry, from your SVC enters the right atrium and right ventricle. Whereas A4 just lie below the IVC. When you see the IVC, this is the IVC structure. This is the IVC, and behind, just below your IVC, you have the coronary sinus opening. So the blood directly enters the right ventricle. That is A4. So A1, A2, A4. So that's a streamlining of blood so that the oxygenated blood will enter the left atrium with the help of the foramen ovale, while the rest of the deoxygenated blood from the IVC, SPC, and coronary sinus enter the right ventricle and go to the respiratory chamber. And after right atrium, what happens? So after right atrium, the blood that goes to the left atrium via foramen ovale and goes to left ventricle, from left ventricle to the aorta to your arch of aorta. From that, brachiocephalic trunk goes to the upper limb as well as to the cerebral circulation. Whereas all the deoxygenated blood from the right ventricle enters the pulmonary artery. But do you know your pulmonary vascular resistance is high because the lung is completely filled with lung, so the PVR is high. So it only 10% of the deoxygenated blood enters the lung, whereas the rest 80 to 90% of blood with the help of the ductus arteriosus get bypassed from the pulmonary artery into the descending aorta to the lower abdominal aorta. From there, it will go to different part of the body to give the oxygenation, mixture of oxygenated and deoxygenated blood. And from that, with the arising of the two umbilical artery, it goes back to the placenta, and from placenta it get oxygenated. And again, this cycle continues. So we already said in right ventricle. So what has happened to right ventricle? So all the right ventricle blood goes to pulmonary artery. But as you know, pulmonary the lung is completely collapsed with the help of because of the lung fluid and high PVR. The blood cannot reach to the lungs. Instead, it get bypassed with the help of the ductus arteriosus. So this is the ductus arteriosus, and this enters the descending aorta, and this will go like that. Whereas the oxygen blood will maximum goes to the upper part of the body at the brain, and it get mixed with the deoxygenated blood that comes via your from your ductus arteriosus due to the IPVR. So this is like a right ventricle, pulmonary artery, only 15% will go to the lung, whereas with the help of the ductus arteriosus, 85% will go to the lower limb and mix with the descending aorta. Whereas left ventricle, the ascending aorta, it will go to the head and neck, 85%. But in descending aorta, what happened? the 15% of the blood get mixed with the deoxygenated blood that comes via ductus arteriosus from the pulmonary from your pulmonary artery. So 85 percentage of the oxygenated blood reaches the head and neck. So this is the dictum we use. So already I told, because the brain is one of the major organs that develop most of this development occurs in utero and first 2 years of life. So it requires more oxygen for the proper growth and development. So that's why 85 percentage of the oxygenated blood reaches the head and neck region, whereas remaining 15% will go to the other part, but with a mixture of the deoxygenated blood. So placenta is the so what are the things you should know about the placenta in fetus? That is the organ which receives the maximum cardiac CVO, cardiac uh, output. So it requires a maximum cardiac output. The site of least vascular resistance and efficiency of oxygen is less than the lung. Though its efficiency is less, but since the lung is unable to oxygenate because of the presence of fluid in the lung, the placenta is the organ where the majority function take place, like your excretion, nutrition, and oxygenation, ventilation. Everything happens in the placenta. That's why the placenta is one of the important organs in the fetus. That's why other organs are dormant. Still they develop, but the main function only occurs like your liver, kidney, lungs. Their function only appears or they mature for an adult a kind of function only after birth. Before that, your placenta take care of all the things. When you go to single umbilical, so what about the structure? We have single umbilical vein, right side or left side. Only left umbilical vein is present, while right side umbilical vein vanishes, and two umbilical arteries. So this is the saturation percentage. So after the from the placenta, where it goes via your umbilical vein into the duct before reaching the IVC, the percentage is 80 percentage. In IVC, it is 70 percentage. In right atrium, because of mixture of deoxygenated blood from the coronary sinus and the SVC, it is 55 percentage. But as I said, the oxygenated blood will bypass this right atrium with the help of the foramen oval with the help of the streamlining, which I showed in the previous slide. So the left atrium will have 65 percentage, left ventricle will have 65 percentage, and from aorta, the head, it will go to head. So the head and the brain receive 65 percentage of oxygenated blood. Whereas the because of ductus arteriosus, the 55 percentage of the deoxygenated blood that is in the right ventricle, it comes to the pulmonary artery, and because of ductus arteriosus, this mixes with the oxygenated blood, and at the ductus arteriosus, we have 60 percentage of blood. Wait a minute. Okay. So this is the percentage saturation in the so in short, the blood from umbilical vein to IVC, IVC to the right atrium. Some of this blood directly enters the left atrium with the help of the ductus foramen oval. Right atrium, right ventricle. Left atrium, left ventricle. Aorta, from aorta, head and neck. And right ventricle, pulmonary artery. But what happened in descending aorta? Because lungs will receive only 10% of blood. Remaining blood, with the help of the ductus arteriosus, goes to the descending aorta. From descending aorta, it goes to the lower limb, another part, and it will go to umbilical artery, and it goes to the placenta. So the saturation percentage. So remember, UV to IVC it is 80 percentage. In IVC it becomes 70 percentage, and in left atrium because of patent ductus, foramen ovale, it becomes 65 percentage in left atrium, 65 percentage because of some mixing of blood will occur while it's bypassing via right atrium. In right atrium, because it receives blood from the coronary sinus and the SPC as well, SVC as well. So it will go 55 percentage, RV 55 percentage, pulmonary artery 55 percentage, and aorta contains 65 percentage, and the brain will receive 65 percentage of oxygen. And ductus artery, there's a mixing of blood. So in ductus, in descending aorta, it will be 50 percentage. Lower limb is also it's 50 percentage. Umbilical artery will contain 50 percentage. And then after all the deoxygenated blood will again go to placenta for oxygenation, and it is 85, 80 percentage. So this is the actual percentage you should know. So another small question is which ventricle is dominant in fetus and its contribution in cardiac output? Anyone? Which ventricle is dominant in fetus? It's left ventricle or right ventricle? It's always it's not a right ventricle. So if this is a question in your fetus circulation, as you know, it's your right ventricle has to you have a high pulmonary vascular resistance, right? So because of high pulmonary vascular resistance, your right ventricle has to work a lot compared to a left ventricle because the SVR is low. Because systemic vascular resistance is low because placenta. Because of the presence of placenta, your systemic vascular resistance is low. So left ventricle has to work very less, whereas right ventricle has to work against your pulmonary vascular resistance, which is high in fetus. So you're always your right ventricle has to work a lot compared to the left ventricle, and also the because of this shunting happens, right ventricle has to shunt this blood through a ductus arteriosus. So more amount of blood will go via right ventricle compared to the left ventricle. That's why the right ventricle is the dominant chamber in the fetus and it contributes to the cardiac output 55 percentage. So right ventricle is the dominant chamber compared to left ventricle. So how much it contributes? It contributes about 55 percentage. So total cardiac output in fetus is mainly contributed by right ventricle, which is 55 percentage, whereas left ventricle contributes only 45 percentage. And the thickness of the right ventricle will be more than the left ventricle. This is very important when we discuss about the acyanotic heart disease, the shunting lesion, left to right shunt, why it appears only after 6 months, why it appears after 2 years. There are few shunt that appears only after 2 years, become prominent after 2 years. Why does happen? That is because of this fetal hemodynamics. So fetal circulation hemodynamics, it will revert back. It will convert to an adult circulation after some time, or like after 6 months. In some case, after 2 years. In some uh, remodeling happens. So it has to remodel, right? Your left ventricle is the dominant. In adult circulation, it's your left ventricle which is dominant compared to the right ventricle. But in fetus, it is opposite. Right ventricle is dominant. And from converting from right ventricle to left ventricle, it takes some time. So, this the gap is known as somewhat. It's a interval where they remain asymptomatic. Why asymptomatic? This is asymptomatic for a 6 month or so, 6 weeks to 1 2 months. This is because this in transition takes some time. That's the reason. Because I said right ventricle is dominant in fetal circulation and it become left ventricle dominance only after 2 years. This remodeling of this musculature takes 2 years. That's why ASD become more if it's a small ASD or somewhat moderate ASD, it takes at least 2 years to present in actual. If it is very significant, only it present after 2 years, not before that. But VSD will present at 6 weeks because it is something different, which we will be discussing in the subsequent classes on acyanotic disease. So now another question which we will be seeing because of the shunting of this because of this variation, the baby can tolerate which type of lesion, stenotic lesion or regurgitation lesion. This could be another one question that could be asked in the viva for postgraduates and also in NEET PG. So which lesion the fetus in utero can tolerate, and but they will present as soon as birth. Because of the presence of shunt, these babies can tolerate stenotic lesion. All your pulmonary stenosis, aortic stenosis, mitral stenosis, tricuspid stenosis with a congenital lesion because of presence of a ductus arteriosus and ASD as a sorry, ASD is patent foramen oval. These children can tolerate stenotic lesion very well in utero, but based upon the severity of lesion, they can present. Once they get born, the shunting lesion gets this they get absolute, right? The shunt get closed functionally as well as anatomically. After that, the shunt is not there, and this lesion will start to manifest, and the child will become symptomatic. Whereas the fetal heart is not able to tolerate any regurgitant lesion and arrhythmic lesion. So all fetal cardiac failure because of fetal anemia or fetal arrhythmias, tachyarrhythmias, bradyarrhythmias, and also the severe mitral regurgitation, tricuspid regurgitation, aortic regurgitation lesions. These lesions the baby will not tolerate. So this is one of the important questions which I just bypassed it. Which congenital heart disease? Sorry. So causes of fetal heart failure or all your regurgitation lesion and arrhythmic lesion. For example, severe valvular regurgitation, which I already said. One is abstin anomaly, which we'll be discussing in the classes. AVCD, that's atrioventricular canal defect, that is your uh, endocardial cushion defect. Uncontrolled fetal arrhythmia, it could be tachycarrhythmia or bradyarrhythmia. Fetal myocarditis, cardiomyopathies, like your dilated cardiomyopathies, restrictive cardiomyopathies, congenital genetic disorders. Recipient twin in TTTS, that is twin to twin transfusion syndrome, and vein of Galen malformation, congenital portosystemic shunts. So these are the few examples causes of fetal heart failure, and this child cannot tolerate. If you are not going to correct in utero, if you are not going to do a surgery in utero, doing fetal therapy, this is known as fetal therapy. You're not doing anything, any management or any surgery or medication, if you're not going to give to the mother or you're not doing any therapy to control it, or else the child will die in utero. Whereas all the stenotic lesion, the child will survive because of the parallel circulation, because we have variation. So the child may escape the manifestation in utero, but soon they are born. This they will start to have symptoms. Okay, so another important thing, so cardiac outputs. Cardiac output is a product of heart rate into stroke volume, right? Stroke volume is a product of preload. It comes to preload, afterload, and contractility. This should be know in adult. If there's a decreased cardiac output, it could be because of what are the reason? Either because there's a decreased preload, volume depletion, your heart is not contracting very properly, myocardial depression, and if that's severe afterload, if afterload is high, like your hypertension. So because of this combination of this uh, 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 combination of these parameters, your stroke volume is impaired. Because of the stroke volume is impaired, your cardiac output decreases and you will have the all signs of shock. So initially in adult, what happened? We have heart rate to what happened? Your heart rate will compensate for that, right? The heart rate will compensate initially, and it will optimize the preload. It will start to shunt all the blood to the vital organs, to the heart. So preload get optimized. It will increase the contractility, and also it will reduce the afterload. So by the way, it do many permutation combination of this parameter, so to that we can maintain the cardiac output and also prevent the uh, prevent the body to go for damage, to prevent the damage. So the body initially will do all this permutation combination with these parameters. So the cardiac output maintains. That phase is known as compensated phase. If after certain time, when body is unable to compensate for it because it is get exhausted, then where only the cardiac output decreases. And the child will have bradycardia, the stroke volume decreases, contractility decreases. Don't want that stage, and we have to treat within that particular time. But in fetus, the stroke volume is not going to have any part in the maintaining the cardiac output, because the preload is somewhat is maintained, whereas contractility, myocardial contraction of your fetal heart is very minimum, and afterload is also, it is very low because of low SVR. The major determinant of cardiac output in fetus is your heart rate. And heart rate is maintained by your sinus rhythm, SA node and other parameters. And it has two autonomic communication, autonomic regulation. One is your parasympathetic and sympathetic. Mind you, in fetus, your parasympathetic system is well developed compared to a systemic sympathetic system. So the reaction for the child is always any fetal distress. So you have read in obsgyne, right? In obsgyne, you have read what is the manifestation of fetal distress? It's a fetal, initially that's the initial fetal tachycardia, but persistence of this distress will lead to fetal bradycardia. So fetal bradycardia is an ominous sign in any CTG of your pregnant mother. Why so? Because your sympathetic system is not that mature compared to your parasympathetic system. So any fetal distress occur, any fetal stress occur, which is not taken care properly in the initial phase, then the child will go for a fetal brady. And fetal brady, the what is the logic behind it? Because your parasympathetic system is well developed in the fetus compared to the sympathetic system. So in the stress, if it is not well properly treated or properly managed, the child will go to the fetal bradycardia, which is an imminent sign of fetal distress, and the child has to deliver immediately. So I have already said the factor that affecting heart rate will be your age, hormone, and autonomic innervation. And already I said autonomic innervation, your parasympathetic is more well formed than the sympathetic. Factor affecting the stroke volume will be your heart size, fitness, and gender. Normally it is said the male heart is comparatively bigger and heavier compared to the female heart, and contractility is limited. Why the contractility of the heart is limited? For the child, the myocardium of the child is somewhat difficult, is immature. What is the component? Why is immature? Will be seeing. And preload is your the venous return, and also afterload is your SVR, systemic vascular resistance. In fetus, it is low because of the placenta is attached, and placenta has least SVR. So, what how the fetus, infant, sorry, this is not infant, it's the neonate, and we can write it as fetus also. How the fetus myocardium is different from the adult myocardium. Now you see in adult myocardium, the myofibrils are the myofibrils are well matured. The content number of myofibrils, myocardial cells are more, collagen is less, water content is less, and they have an inbuilt system of storing calcium. So we have calcium storage vesicles are also there. So the myocardium of the adult is well formed, whereas in neonate and also in case of your fetus, what happens? These are not formed very well. They have high water to collagen ratio and high collagen to contractile relation. Means the contractile tissue is very limited. So the compliant nature of the myocardium, contractility nature of the myocardium is less. This is the reason, because they have more water and more collagen compared to the contractile tissue. As a result, the compliance of the myocardium is low, and also they have fewer myofibrils, and they are not well organized, which is seen in adult myocardium. And then they have fewer mitochondria. Mitochondria is essential for the energy source. So in neonate and fetus, this myocardial cells have fewer mitochondria, and always the myocardial contractility, it requires energy, ATP, and calcium, right? The calcium is important. If the calcium is not provided properly, the myocardium cannot contract properly. In adult, we have a in-out storage. In within the myocardial cell, we have calcium storage vesicles. But in neonate, there is no that specific vesicle, and T tubules are not well formed. When this is not well formed, it has to depend on the serum calcium. And in initial phases of fetus, on neonate, your serum calcium will decrease. So initially, any myocardial depression occurs before going for inotrope support, giving before dopamine, epinephrine, norepinephrine, anything. Always see ionized calcium level in the serum because the fetus as well as the neonate will depend on the serum calcium, ionized calcium for the contractile function. So if the serum calcium is not that much is very low, then despite giving all the inotrope support, the art myocardial contraction will not improve because the calcium is not there. That is the reason. The neonatal myocardium, they have more water and collagen content compared to the contractile tissue. What are the contractile tissue? That is your myofibril. This myofibril are very fewer number and they are less organized. And within this myofibril, the mitochondria is also very fewer and they are small and they are immature. And also the myocardium of the fetus and neonate will depend upon the ionized calcium, not your because they don't have the ability to store calcium within them, and also the T tubules are not well formed. These are the reason why the fetus myocardium contractility is very poor in a fetus as well as a neonate. So you know how come the fetus tolerate low PaO2? The only two reason is the fetus hemoglobin, right? HbF. It has the high affinity and the total the cardiac output is two times more than compared to adult cardiac output. So when you see the adult cardiac output and the fetus cardiac output, they have the high output cardiac. Let's say they have high output status. So they have the cardiac output is two times more than compared to adult cardiac output and presence of hemoglobin F. That's the reason why the fetus tolerate the low PaO2. So I already told. So whenever the heart rate, the cardiac output is dependent on heart rate. So when you see this at rest, when the child is at rest in utero, and this is the heart rate, right? So at rest, as the heart rate increases, the stroke volume also increases. But after particular level, the stroke volume decreases because after that particular cardiac heart rate, the child cannot unable to pump the blood because there is no filling of the heart will occur. After 180, 220, for example, if the heart rate is more than 2 and 220, there is no, it will just pump like this. If it is going to pump like this, there is no space for filling. There is no filling or diastolic filling occur. So what the heart will pump back into the circulation, so it is not going to happen. So up to 180 beats per minute, the baby can increase the cardiac output. After 180, 200 per beats per minute, the cardiac output cannot be increased because there is no proper diastolic filling of the heart is happening. So there is no blood filling of in the heart is happening. So there is no way the cardiac output can be increased. So increase in cardiac output is mainly affected by heart rate. Hence, if there is fetal bradycardia, you have to the child will go for shock. So you should be very important if the fetal bradycardia. That's the another reason why fetal bradycardia is a very imminent sign. Fetal bradycardia is an imminent sign of the child is in a prolonged stress which has been not taken care properly by the physician because it has been missed. Second thing, if the persistent fetal bradycardia, what happened? I already told the cardiac output is solely depend on the heart rate rather than the stroke volume in the fetus. If you are not going to increase the heart rate, the cardiac output will decrease. The child will go for fetal hypertension, the shock, and the child may die in utero if the child is not uh, removed. The child, if the child is not born immediately. So these are the silent features of the fetal circulation. So what we discussed now is the fetal circulation, how the fetal circulation is different from the adult circulation. Second, how this the normal flow of this fetal circulation occur and how this parallel circulation operates. What are the importance of the parallel circulation at the level of before the right atrium, at the right atrium, after the right atrium, and then we also discussed about the percentage of the oxygenation at various chamber of your heart and the circulation. And we say what are the lesions which the fetus can tolerate, what are the lesions the fetus cannot tolerate, and cardiac output of the fetus depend on heart rate rather than the stroke volume, and what are the features that distinguish the fetal myocardium from the adult myocardium, and what is the imminent, why fetal bradycardia is not at all good, and why the child has to taken uh, uh, to a, the child has to be given birth immediately if that's a persistent fetal bradycardia. So this is a just note about the fetal circulation. Now the child is born, right? Now after the child is born, now I already told the fetal circulation is meant only for fetus. But now the fetus has to adapt. Once the neonate is born, it has to adapt to the extrauterine life. So what are the things which has to go off the child? What are the things that happen after the child is born? One, the first the child cries. So that is very important. Cries immediately after birth. So what happened? The child cries immediately after birth. So what happened? So air enters the alveoli. When the air enters the alveoli, it will push the fluid. Already the fluid has been removed. Push the fluid from alveoli into the interstitium, where from there it goes to the lymphatics. So when oxygenated blood, so this oxygenation, the PaO2. So what happened? This oxygen, this oxygenation, right? Oxygenate the. Sorry, it is not writing. Okay, I have to charge it. Okay. So what happened? Wait. So I will say this. So first, that is air enters the alveoli and it pushes the fluid from alveoli into the interstitium, into the lymphatic. Now what happened? This will increase the oxygenation of the. This will reduces the pulmonary vascular resistance, right? Because when there is an oxygenation, the pulmonary vascular resistance decreases. More of this pulmonary blood will now have a pulmonary circulation. Since the pulmonary vascular resistance is increased, the shunting of blood of pulmonary artery into the descending aorta via the ductus arteries will not happen. All this blood will enter the pulmonary circulation, and the oxygenation of the pulmonary this blood will occur. So the PaO2 of the blood from 25 mmHg will go for the 45 mmHg, 50 mmHg. When the oxygenated blood goes, it enters back to the left atrium, left ventricle, and when it goes to the ductus arteriosus, number one, when it goes to the ductus arteriosus, what happened? Ductus arteriosus are highly sensitive to the oxygen, so it starts to have the functional closure. So ductus arteriosus closure. Second, you are also cutting the umbilical cord. When the umbilical cord is cut, the placenta get the placenta is removed, so the superior the SVR, that is the systemic vascular resistance, increases. When the systemic vascular resistance increases, your left atrium and left ventricle pressure will also rise, because now the right atrium, right ventricle pressure decreases because pulmonary vascular resistance decreases, so it has to work very less. Whereas the SVR now increases, so left atrium, left ventricle has to now work more so that it can pump the blood against the systemic vascular resistance. So what happened? Automatically, the left atrium pressure increases compared to the left ventricle pressure. Left atrium pressure increases compared to right atrium pressure. So the flap mechanism that was operating the foramen ovale will closes this foramen ovale. So foramen ovale is closed, ductus arteriosus is closed. And third one is ductus venosus. Once you cut the umbilical cord, ductus venosus will also close by 7 to 14 days. So what are the things which are happening? One is the decrease in the PVR, increase in the SPR, and closure of the shunt. These are the three mechanisms that occurs in the transition of the birth. And if it occurs properly, then the child will have a normal transition. If anything abnormal happens in this transition, then only the child will have some difficult, or it may, most of the time, if that's a difficult or delayed transition process because of various problems, then the child, we can say the child may have many pathophysiology. One of the pathophysiology or one of the pathology is your birth asphyxia, perinatal asphyxia, if there is a delayed or abnormal transition that occurs. Another point is your ductus arteriosus. This ductus arteriosus closure is also important in various congenital heart diseases, which depends on the ductus for the systemic as well as the pulmonary circulation. If it is not going to happen properly, then if it is closed, prematurely closed, or it's closing, then the systemic and pulmonary circulation get hampered, and the child may present with shock as well as cyanosis. So that's why this transition of fetal circulation is very important, because this is important not only as a normal physiology, in abnormal physiology also, how it play an important role. It should be known. So why does an IPVR? So I already said these are the three things that happen. So baby's first birth, that's an increase in SPR because you are going to cut the placenta, which has a least resistance part, and because of that, that's a large rise in SVR, and has fall in PVR. Why does a fall in PVR? Why does a reason for IPVR is one is mechanical factors and one is chemo reflex, that is hypoxia. Because of hypoxia, what happened? Your vasoconstriction factors increases. You already read in pulmonary in your physiology, hypoxia causes pulmonary vasoconstriction. That is known as hypoxic pulmonary vasoconstriction. So hypoxia will increase the vasoconstriction by increasing the production of thromboxane A2, PGF2 alpha, and ET1. Whereas it decreases the production of vasodilator like EDNO, PGI2, and ANP, BNP, and CNF. ANP and PNP. Whereas about the mechanical factor, when you see the fetal lungs are collapsed because of the fluid and minimum blood flow. So what happened in the pulmonary artery near term? It will be completely thick wall pulmonary. So you see thickened wall. This is the thickened wall because of the muscular layer of the pulmonary artery. That is a pulmonary adventitia. The adventitia, the media. The media part of the pulmonary artery, tunica media, is thickened because of the muscular coating. But once the child is born, what happens? This coating will undergo remodeling. So by 24 hours of birth, all this tunica media get constricted, so that is a widening of the lumen and more pulmonary blood flows also because of oxygen. One is oxygen is increased, so pulmonary blood flow is increasing, oxygenation increases, it will cause the constriction of the tunica media. I'm not talking about the constriction of the vessel per se, I'm talking about the constriction of the tunica media. So these are the thing which appears after birth. After birth, what happened? Because of oxygenation, there's a constriction of the tunica media. So the lumen size of the pulmonary artery increases, number one. And what was happening? The vasoconstriction is because of the hypoxia. Now, hypoxia is removed because of the oxygenation of air is appearing. As a result, the thromboxane A2, PGF2, they will get washed out. Whereas vasodilator will increases. So, how this pulmonary artery or pulmonary vascular resistance decreases? It by four stages. What are the four stages? One is phase zero. One is what is this phase zero? Phase zero is there is a slight fall in the PVR just prior to birth. That is mainly because of the inact channel. Because there is the removal of fetal. So once the onset of labor begins, so onset of labor, what happens? Your in mother, what happens? Your glucocorticoids, cortisol, and catecholamines are released, right? This glucocorticoids and catecholamines, what it does, it will act on the inact channel that is present in the fetal lung, alveoli membrane. Now, this inact channel will cause us the removal of the fluid from the. So, this is the inact channel here, like this. So, this is full of fluid. So what happened because of this glucocortic catecholamine that is released during this process? So, during this process, what happened? This will act over this channel Inact channel is increased, so you have more inact channel right now. So what it will reabsorb the fluid, so it get opened up. So this, as a result, this process will reduce the slight PVR. Just before the birth, the PVR reduces slightly. That is a slight fall in the PVR. Second is early rapid fall will occur in the first 96 hours. That is first 4 hours, 4 days. In first 4 days, there's rapid fall. What? Why? It's the same thing. There's an expansion of the alveoli because of the hair. It increases the pulmonary blood flow because of the oxygenation. The PaO2 of the pulmonary circulation increases. Sorry, pulmonary blood will increases from 25 to 50 mmHg, and this will cause vasodilation. Simple. Now, what are the causes of delayed PVR because of the problematic in the early rapid fall? One is if the child is born via LUCS. When the child is born of LUCS, the alveoli still is filled with fluid. So when the alveoli still contain fluid, it takes some time to remove the fluid from the alveoli into the lymphatics. For that, it takes some time, right? So till then, the child will have the IPVR. So this is one thing which is no we see no state as TTNB, transient tachypnea of newborn. Another thing, if the child, that is by a C-section, that is one is C-section. If the child is have persistent hypoxia, what are the condition the child have a persistent hypoxia? Because I said hypoxia will cause vasoconstriction. So what are the condition which predisposes a persistent hypoxia in a neonate? One is if the child is already having some lung diseases like pulmonary diseases, meconium aspiration syndrome, or if a child is a premature child with RDS, and that if the child is born in a high altitude. So these are the conditions where there is a persistent hypoxia, percent hypoxia, which causes hypoxic vasoconstriction. And if the child is gone undergoes C-section, so they will go for TTNB. TTNB because there is delayed clearance of fluid. So this is phase one, that is early rapid fall, which occurs within 48 to 96 hours. In phase two, that's a late decrease. It occurs at least 4 to 6 weeks. This late clearance of the fluid, sorry, not late. The late reduction of the PVR is mainly because of the remodeling of the pulmonary artery. So when the remodeling of the pulmonary artery is occurring, it takes some time because as I say, the tunica media is thickened in a fetus at term. Now it has to remodeled so that the thickness of the tunica media is decreased. How it how it occurs is because that by a process called as PA involution. PA involution is a progressive involution of the circumferential medial smooth muscle with overall reduction in medial muscular thickness of the wall of small pulmonary arteries. So when this occurs, the pulmonary artery get the thickness of the pulmonary artery or pulmonary thickness decreases. As a result, the child PVR will further fall. Now, this fall is the maximum fall that happens in the child. So that's why there are few lesions of left to right shunt will appear only after the 4 to 6 weeks. So this is the reason why questions have been framed. Why VSD is appearing only after 6 weeks, not at birth. The reason is the maximum reduction of the pulmonary vascular resistance will only occurs at the 6th week because of the process called as PA involution. And phase three that occurs at the third decline at the age after 2 years because your surface area of the pulmonary capillaries and also the alveoli increases, right? That the time further small reduction of PVR occurs. So maximum reduction of PVR will occur at the time of 4 to 6 weeks by the process of pulmonary artery involution. So what are the four stages? Phase zero, slight decrease just before birth because of the inact channel and rapid fall of PVR within 96 hours of life because of the high oxygen content of the blood of the pulmonary artery because of the oxygenation on the alveoli opening leading to the vasodilation. Third one is late fall of PVR that occurs at 4 to 6 weeks. This is the major reduction that appears, and it is mainly because of PA involution. And phase three is the third decline that appears only after the 2 years. So what is the clinical importance? I already said if the PVR is not going to reduce persistent increase in PVR because of the persistent hypoxia or fluid delivery, like your mass or in a pulmonary disease, a premature baby with RDS. This will cause a persistent rise of PVR. This is known as persistent pulmonary hypertension, that is known as PPHTN. And And already I have said after 6 weeks why the VSD appears only after 6 weeks, not before that. Because when the pulmonary artery involution occur, the maximum PVR decreases. So now the left ventricle pressure is the right ventricle become very compliant, right? Right ventricle become compliant. Now it receives the shunt blood from the left ventricle to right ventricle and it enters the pulmonary artery and it will cause congestion of the lung and the child will present with recurrent respiratory tract infection. That is the post-tricuspid shunt. So we have two terminology, pre-tricuspid shunt and post-tricuspid shunt. This is nothing but this is your heart, right? This is the right atrium, right ventricle, left atrium, left ventricle, aorta, and pulmonary artery. So you have one is ASD, you have a VSD lesion, and you have patent ductus arteriosus. So this is the tricuspid wall, right? All the lesions which is seen above the tricuspid wall, it's known as pre-trus, uh, pre-tricuspid lesions. All the lesions that are seen below the tricuspid wall, like a VSD, patent ductus arteriosus, they are called as post-tricuspid lesion. So we are worried with the posture because VSD will not, ASD will not appear after 6 weeks because it takes some more time. At least if it's a significant ASD, large unregistered ASD, it may appear, I think, most likely after 1 or 2 years. That is reason. The reason is because there is also your right ventricle is also hypertrophied because right ventricle dominance was in utero. Fetus has a right ventricle dominance compared to the left ventricle. The right ventricle to left ventricle transition, it takes at least 2 years to happen. That's the reason ASD takes time, at least 1 to 2 years after birth. Whereas the VSD and PDA may appear, PDA is something different. The VSD will appear before, after 6 weeks because the PA involution occurs. Maximum PVR decrease occur after 6 weeks. So now the right ventricle become compliant and it receives the shunting of the blood will be more prominent from left to right, and the VSU will present after 6 weeks. This is one of the important question, clinical short notes and Viva. Also, they ask why VSD appears after 6 weeks, not before that. And there must be there is also another trick question where they can ask, is there any situation where VSD can present before 6 weeks? Anyone? Is there any situation where VSD can present before 6 weeks? So already I said pulmonary artery pressure is more. The maximum reduction of the pulmonary artery pressure. So simple logic is that okay, you have this is left ventricle. This is left atrium. It is the right atrium. It's the right ventricle. and this is your uh, pulmonary artery. This is your aorta, and this is ductus arteriosus, right? So, what is the question? As already told, the VSG will only present after the 6 weeks because your pulmonary involution has not taken. So pulmonary still this pulmonary involution, pulmonary artery is thickened, so it is giving more resistance to the right ventricle to pump the blood into the into the pulmonary artery. Like after 6 weeks, the pulmonary involution, pulmonary artery involution occur. So right ventricle has not to is not having that much resistance against which it has to pump blood. So it become compliant. So it will receive all the blood from the left ventricle to right ventricle, and the shunting will become more prominent, and the shunting will more prominent, and you will the child will manifest as a VS deletion. So, but the question is that in any other way where the VSD can present before 6 weeks? So this is one of the tricky question where when VSD will present before 6 weeks. One is so the logic is that the right ventricle has become should become compliant. How it will become compliant? Only when the pulmonary artery pressure decreases. When it will decreases when the pulmonary artery involute. So the resistance against with the right ventricle has to pump blood will also decreases. So now the right ventricle is become very free to pump as much as blood possible. So the shunting will also become prominent. So the right ventricle pressure is somewhat more than the left ventricle pressure, or they are equal. As a result, the shunting is not occurring before 6 weeks. But once the pulmonary artery involution occurs, the resistance decreases, right ventricle pressure will decrease compared to the left ventricle. So the compliance of the right ventricle is also improved. So the shunting of blood will occur from the left to right side. So there are few lesions where you can increase the left ventricle pressure to the from against the right ventricle. So when the left ventricle pressure increases more than the right ventricle before 6 weeks, then the shunting become prominent. Like your critical aortic stenosis and critical severe coarctation of aorta, and in a preterm baby with RDS. Sorry, preterm baby with normal oxygenation. So critical aortic stenosis, coarctation of aorta with preterm with normal oxygen. The reason you can ask why, sir, you told that PVR is raised in a in a in utero. So how come a preterm baby with normal oxygen can present before 6 weeks? The funda is that before 32 weeks, the pulmonary vascular resistance is minimum. The pulmonary vascular resistance reaches its maximum. It starts to increase and reaches its maximum after 32 weeks. So any preterm baby who are born before 32 weeks, but without respiratory distress syndrome. If there is a respiratory distress syndrome, I already told respiratory distress syndrome will have some lung disorder. It's a lung disorder. That's island membrane disease. So that in turn will cause hypoxia, and hypoxia will cause pulmonary vascular resistance. That in turn will cause a PVR raise. But I am talking a preterm with a normal oxygenation who have no RTS, they will may have this VSD before 6 weeks also because the PVR is already low from the beginning itself. It starts to increase only after 32 weeks. So any preterm baby before 32 weeks with normal oxygenation, no RDS can present before 6 weeks. Whereas the critical aortic stenosis and coarctation of aorta ka funda hai, here the pressure of left ventricle is much higher than the right ventricle pressure, which is which is for your overcome the resistance of the pulmonary artery pressure, but already the left ventricle pressure is much higher than the left right ventricle. So before 6 weeks itself, the shunting will become prominent despite the pulmonary vascular resistance. So these are the three conditions where the VSD can present before 6 weeks. So I already told it. So VSD, preterm VSD with normal oxygenation, coarctation of aorta, aortic interruption, and critical aortic stenosis. PDA can present before 6 weeks because of preterm PDA with normal oxygenation. So these are the few examples you should know. And mind you, pulmonary artery is sensitive to get vasodilated with oxygenation, vasoconstricted with carbon dioxide. Whereas cerebral circulation become vasodilated with high PCO2. PCO2 will cause vasoconstriction in pulmonary artery, whereas the cerebral circulation will get vasodilated. And the vasodilation of the pulmonary circulation is basically by your oxygen. Mm. So now we will talk about the closure. I already sure ductus venosus will close as soon as you cut the umbilical cord, and it will take few hours to 7 days to complete closure of the ductus venosus. And second is foramen oval closure. The foramen oval closure is increased in the left atrial placenta. I already told when you cut the placenta, the systemic vascular resistance increases. When the systemic vascular resistance increases, now left atrium or left ventricle has to pump blood against the systemic vascular resistance. So the pressure in the left atrium, left ventricle will also increases, whereas the right atrium, right ventricle pressure will decreases because the pulmonary vascular resistance decreases after birth. So now the right ventricle, right atrial pressure is less, left atrial pressure is more. Because of that, the flap which is operating in the foramen level will close will get closed over the septum secundum, and this will close the foramen oval. Whereas in 25% of adult population, you have a probe pattern foramen oval. And what about the ductus arteriosus? Ductus arteriosus functional closure will occur 10 to 15 hours after birth in term neonate due to vasoconstriction. Why the vasoconstriction occur? Because of the oxygen. The ductus arteriosus are highly sensitive to oxygen. In anatomical, in 2 to 3 weeks, it takes time because of the smooth muscle proliferation. A functional closure will occur within 10 to 15 hours after birth in term neonatal due to vasoconstriction. In anatomical closure will occur 2 to 3 weeks because of the smooth muscle proliferation. And the question is, what are the factors that keep the ductus arteriosus open? One is your low PO2, hypoxia. Another is high PGE2 and high altitude. So any neonate who is born in high altitude place like Ladakh, in OT, Kodaikanal. So if you go to Darjeeling, these are the high altitude place. So these babies will have the patent of this ductus arteries will open for quite some time compared to the other babies who are born in the terrains. And other, if what are the causes of premature closure of PDA in ductus arteriosus? If the mother is inadvertently given aspirin. So what there was a case. It happened recently in Tamil Nadu. I guess it's in Tamil Nadu. What happened? Mother was came to the antenatal checkup. Okay, in antenatal checkup, it also came the news actually. So this mother of 28 days, 28 a week, she was I think 20 to 22 weeks mother. She came to the antenatal checkup and on her thyroid report was low. So she was suffering from hypothyroidism. So the doctor, what he wrote, he prescribed Tylenol. What is here? Levothyroxine, which is a common drug we will prescribe. But what happened when she went to the pharmacy of that hospital, particular hospital, the state hospital, instead of giving Tylenol for the patient, so what happened? Writing this drug, क्या होता है ना? What they did, they wrote this Tylenol. They didn't wrote Tylenol as say they wrote this L-toxin. They wrote L-toxin, but there was some other brand. What happened? Instead of giving L-toxin, they give aspirin for this mother. That is an ecosprin. I guess everyone can go with this name, right? L-toxin and ecosprin. So what the pharmacist was confused because the handwriting was not legible of the doctor. Even it was not legible, not it was somewhat legible because it was not like that. He wrote like this. He wrote L-toxin only, but the pharmacist mistakenly given ecosprin because both are starting from eco. Sorry, not echo. The spelling is e. So he mistakenly, inadvertently given ecosprin to the mother, and she took this tablet for next 4 weeks, 4 to 6 weeks. They don't didn't have doubts, but when after what happened after 4 6 weeks, they again went to another pharmacy of other hospital, and they saw that this mother is having this tablet. They were shocked because she was suffering from hypothyroidism and she was taking ecosprin. Then only they found out the huge gross mistake that was done by that pharmacy. So what happened to this mother? What would happen if the child is given if the pregnant mother take ecosprin? Anyone? If a pregnant mother take ecosprin, what would be the problem? The actual is aspirin will cause because it is prostaglandin inhibitor. And your prostaglandin E2 is important for the, as I already told, what are the things which is important for keeping your ductus arteries open? Your low hypoxia, IPGE2. So IPGE2. So the PGE2 production is very important. If your PGE2 production gets decreased, then that's the ductus arteries will close prematurely. So what happened in this case? Because of giving echosprin, the mother, what you can anticipate? Yeah, there may be a premature closure of ductus arteriosus in utero. So that's why be vigilant, write legitimately. Whatever drug you are prescribing to the patient should be written in full capital letter in a full generic name. You should write only the generic name in the capital letter and it should be undersigned and it should be rechecked. If you are doubting, you have to ask the patient to bring back all the medicine after buying from the pharmacy. You recheck it and then only you have to say that, then only you have to leave the patient because many times it happens. And for this mother, after 6 weeks, he has taken ecosprin. So this mother is under now regular monitoring, and she will have a regular monitoring so that we will be seeing whether the ductus arteriosus is closed or not. So that's why be very very careful while prescribing a drug and write legitimately. Also write properly in a generic name and in a complete uh, full form. You have to write full capital generic name and should be signed, should be written legitimately, write the dose properly, write the time, duration, and also recheck by saying the patient party to take so patient attenders to bring back the medication after buying and recheck, and then only you have to send the patient back to the home. So in vitro closure of ductus arteriosus will also go for PPH. This will also cause PPH. So what are the problems faced by the premature newborn? That is high incidence of PDA will happen. One thing is that if prematurely they are born, they have hypoxia, RDS, so they have a ductus arteries remain open for a long time. And because of the preterm baby may have more predisposed IVR, they have a PPHD. So preterm baby may have high incidence of patent ductus arteriosus and also high incidence of pulmonary increased pulmonary vascular resistance, leading to increased PPHD. So what this table is very important for your exam. In case we have a Viva, also for your could occur a short note. What are the fate of different structures that happen in this different structures in utero? What is their fate after the child is born? One is your foramen oval that will close fossa ovalis. They become fossa ovalis. Ductus arteriosus, they will become ligamentum arteriosa. The left umbilical vein, right umbilical vein is not present. So what are the parts that is present in umbilical cord? If someone asks, this is the umbilical cord. It is a large patulous thing which is easily collapsible. This is left side में रहता है. It's present in left side and it's a large collapsible structure. This is known as umbilical vein. And this umbilical vein only left side of left umbilical vein. Whereas right get vanished. Now this left umbilical vein has two parts, whereas the other before going to umbilical artery, what about this umbilical artery? They are the small dot-like structure, and they are just raised. You see two cord-like structure, two cord-like structure. They are well raised above the surface of this umbilical cord. They are called as they are umbilical vein artery. So how to identify umbilical vessels is also important. So you have a large collapsible vessel in your umbilical artery, mostly in the lower side, the left side. It's always umbilical vein. Two cord-like structure just raised above the umbilical surface of this umbilical cord. Then it's an umbilical artery. We have two umbilical artery and two A, one V. This should be seen soon after birth. This is the easily missed anomaly in any birth. So one of the anomaly which can be easily missed during birth is your umbilical vessels, because most of the time we cut it, but most of the time we just don't give it because the child is crying, everything is normal, so we don't give any importance to this structure. So this is the structure which is easily missed. So most of the child have single umbilical artery, so that's why it should be taken. And this is the only thing which you can see only at birth. After birth also you can go and check it, because most of the time the cord fall off and you don't know what is that. So this is the lesion should be seen only at birth, and it can be easily missed. So what happened to the umbilical vein? That is the left side umbilical vein. We have extrahepatic component and intrahepatic component. What about the extrahepatic component will become ligamentum teres hepatis, whereas the infrahepatic portion will become ligamentum venosum. Whereas your so that will be ligamentum venosum. What about the umbilical artery? We have two umbilical artery, so proximal portion and distal portion. The proximal portion of the left and right umbilical artery will become the umbilical branch of the internal iliac artery, whereas the distal portions of the left and fetal left and right umbilical artery will become the umbilical ligament. So fossa ovalis, foramen oval become the fossa ovalis, ductus arteriosus become the ligamentum arteriosum, extrahepatic of the left, extrahepatic portion of the left umbilical vein will become the ligamentum teres hepatis, whereas the infrahepatic portion will become the ligamentum venosum. Proximal portion of the left and right umbilical artery will become the umbilical branch of the internal iliac arteries, and the distal portion of the fetal left and right umbilical artery will become the umbilical ligament. So these are the fates of the different structures in the thing. So this is the so in this last 1.5 hour we discussed about the fetal circulation, how it is different from the adult circulation, and how the streamlining of this oxygenated and deoxygenated bed is occurring. We also talked about fetal myocardium and fetal cardiac output. Uh, uh, we briefly discuss about fetal cardiac output and fetal myocardium, and how the fetal circulation transmission transition occurs from the fetal circulation to the neonatal circulation. What are the phenomena is important. Only three phenomena: decrease in SVR, decrease in PVR, increase in SVR, and closure of shunt. And what are the clinical importance of each and everything we discussed. And also, at finally, we discovered fates of the different structure. This is all about the fetal circulation. So I guess today it's going off lengthy. So I would end with giving just some importance, just a gist of the congenital heart diseases approach. What will be doing in the subsequent classes, and just give a short 10 minutes. I'll just touch about it, but I will give an we will describe it elaborately in the subsequent other classes. So approach to congenital heart disease in neonate. Why it is important? As a MBBS graduate, and also for first year postgraduate trainee who's been in emergency room, you're going to have a 4 month old child. Sudden mother is coming with in a either a labor room or at a emergency, pediatric emergency. You are having a child born after. If you're taking emergency room, the child is coming at it has been outborn, and fourth to fifth day of life, the child is coming with cyanosis, and you are seeing preductal, postductal saturation. Preductal saturation is 65. Postductal saturation is also 60, 65. You have given oxygen, the oxygen, or even after oxygen, the child is not improving. And the child, that's no that much of respiratory retraction is not there. Respiratory rate is okay, and you are having a faint murmur. So how to differentiate this as a respiratory cause or cardiac cause? That is one thing, because sinuses can appear in respiratory as well as cardiac cause. How to differentiate? By history as well as by examination. What are the tests you can perform in the bedside to confirm, yeah, this is a cardiac cause? Bedside minimum test. What are the things? This we will be discussing in the subsequent classes. And how the child can present in a congenital heart disease. Either the child may be cyanosed, or the child may present as shock. Child will be pink, but the child will have a recurrent respiratory tract infection. So these are the three ways by which, yeah, congenital heart disease will present in a neonate. In labor room, how they will present, and in emergency, how they will present. So these are two different scenarios. What are the labor room? So this is the thing which will be any baby who present within 24 to 48 hours of life, and they require some intervention immediately for the survival. It is known as critical congenital heart disease. What is critical congenital heart disease? Any congenital heart disease that present within 24 hours, or but as per textbook within first 28 days of life. But most of the severe congenital heart disease may present within 24-48 hours of life. Any congenital heart disease that present within first 28 days of life and require emergency intervention, emergency surgical or medical intervention for the survival of the baby in next 28 days, or in some book they are also given you can do a palliative surgery, but definitive procedure, palliative procedure for making the child till the child gets stabilized, for a definitive surgery. So at least a palliative procedure should bridging procedure or palliative procedure should be performed within the first 28 days of life, and the definitive procedure should be performed within the 1 year, so that the child will survive. Or else there's a high mortality rate. Or within 1 year of life, that is known as critical congenital heart disease. So approach to critical congenital heart disease. So already I told you, doctor, my baby is turning blue. That is a cyanosis. Now, what is this? So the patient mother or a parent, they become very anxious, and they bring the child to the emergency room. These are the three scenario we are going to see, and how to approach. We will be discussing as in the upcoming sessions. We will be discussing in detail with each and every cyanotic heart disease, acyanotic heart disease, administered physiology, TGF physiology, top physiology. So now, first scenario is, doctor, my baby is turning blue. Now this is known as cyanosis. Central cyanosis is very important. We are not worried about the peripheral cyanosis, because peripheral cyanosis can occur in for many causes, but central cyanosis only two causes: respiratory cause and cardiac cause. Respiratory and cardiac cause, how to differentiate? Simple thing is by history taking. If there is a cough and coryza for a long time, low grade fever, severe retraction, but there is no murmur, and by giving oxygen, or by when the baby cries or when giving oxygen, if the child is improving and there is no cardiovascular examination or unremarkable, then it's most likely a respiratory cause. Okay, this is a simple way of differentiating a respiratory cause. Whereas in a cardiac cause, the child will have a prolonged cyanosis, central cyanosis. That is, the child now have preceding cough, coryza, URTA infection, like of anything kind of that, and they have a peaceful cyanosis. What is mean by peaceful cyanosis? What is mean by peaceful cyanosis? Peaceful cyanosis mean the child have a central cyanosis, but the respiratory rate is low, respiratory rate is normal, or there is no retraction. This means retraction nahi hai. There is no component of respiratory diseases, but the child is have cyanosis. That is known as peaceful cyanosis. If you're seeing a baby with cyanosis, but there is no signs of respiratory distress, there is no subcostal, suprasternal, intercostal retraction, recession, nasal flaring, grunting, that means it most likely a cardiac cause. And when you do a X-ray, you may be apparent cardiomegaly, you can see. Okay. And also ECG, abnormal S2 sound, abnormal murmur, you can visual abnormal BP. It is seen in a cardiac cases. And if you do an ABG also, in ABG, if it's a respiratory cause, your PCO2 will be raised because that's a respiratory retention of this carbon dioxide will occur. Whereas for a cardiac cause, your PCO2 will be normal. So by this physical examination and certain history, you can differentiate whether it's a respiratory and cardiac cause. Once you have proven this is a cardiac cause, then you have to prove what is this. This cyanosis is mainly because of it's because of duct dependent and duct independent. That is very important. If it's a duct dependent, then duct dependent lesion will present within 24, 48 or 72 hours of life because ductus closure will appear within 72 hours. The anatomic functional closure will start. Mostly functional closure will end by 72 hours. So this kind of children who are depend on duct-dependent pulmonary circulation, they will present within 72 hours. Whereas like TOF baby, which will take some time, at least 1 to 2 weeks of the birth, the TOF physiology, tetralogy of Fallot baby will present. This is one scenario. Second scenario, doctor, my baby is turning gray. What is this gray means? Ashen color. So when you say the ashen color, when there is no proper skin color. So when the proper skin circulation is not there, then only the color will be like a pale color. This means the baby is presenting with shock. So the scenario for this kind of cases will be the child have an uneventful birth history, cried immediately of birth, no essential admission, discharge on day 3 with everything was normal. But on day 5 or day 7, the child is coming back to the ER with complete severe shock. You are resuscitating the child. Still, after even resuscitating, the child is not improving. So always any baby who come with this kind of gray color or ashen color, skin circulation is proper skin color circulation is not there. CRT is prolonged, oliguria, altered vein sensorium. Always you rule out sepsis first. The diagnosis must be a sepsis. You start antibiotics. You watch whether child is improving for 24 hours or for 24 send all the relevant investigations, but always keep in mind as one of the DB for shock is your duct dependent systemic circulation. Same funda. When after 72 hours, what happened? Your ductus closer, all duct dependent systemic circulation, like your critical coarctation of aorta, critical aortic stenosis, interrupted aortic arch, they will and hypoplastic left heart syndrome, they will present after 72 hours because till before that your ductus arteries was patent, so it was circumventing the blood to the circulation via the ductus arteries. But when the ductus arteries closes, all this lesion will manifest after 72 hours. So you have to rule out the ductus dependent systemic circulation after ruling out sepsis. Still, after giving appropriate antibiotic, appropriate support, the child is not improving. Do an echocardiogram and rule out the condition. Rule out that condition, and also genetically, if the child is having cardiomyopathy or arrhythmias, they can also present as this as a shock-like presentation. The neonatal shock-like presentation after ruling out sepsis, always rule out duct-dependent systemic circulation, congenital heart disease. In any blue baby, always first see whether there's a respiratory component present or not, respiratory distress is there, or respiratory cause of the cyanosis. If not, always rule out cyanotic congenital heart disease. Third is, doctor, my baby is pink but breathing heavily. This is condition of all your left to right shunt. That is your VSD and sometimes ASD also. So this first condition, the mnemonic for this doctor, my baby is turning blue is a blue baby syndrome. That's cyanotic heart disease. Doctor, my baby is turning gray. This is gray baby syndrome. That is the baby is presenting as shock-like presentation after ruling out sepsis. Always rule out duct-dependent systemic circulation. Doctor, my baby is pink but breathing heavily. There's a recurrent respiratory tract infection. This is known as pink baby syndrome. It's mostly seen in your acyanotic congenital heart disease with left to right shunt. How to proceed? I already given a brief description of each and every syndrome, how to see, how to assess, and further detail we will be discussing in the subsequent classes, which will be shared in which will be subsequently shared in the WhatsApp group. So with this, we will end the lesson. Any doubt you can ask for next 10 minutes. We can discuss any doubt related to the fetal circulation and this short description on the approach to congenital heart disease. So with this, we will wind up the today's session. Raghu?
Yes, sir.
Uh, so we ended up the session right now. So if any doubt in YouTube live, they can ask in next 5-10 minutes. We can go with that, or else we can wind up the session today.
Sure, sir. If anyone have doubt, they can also post it in the WhatsApp group we have.
Yeah,
So
yeah, yeah,
they
yeah, yeah.
answer directly by sir.
Sure.
If not, we can end the session, sir.
Okay, then I guess it's better to end. Okay, so today we had a discussion, elaborative discussion on the fetal circulation and some short description of how to approach a critical congenital heart disease in a labor room as well as in the emergency room. How to see in a blue baby, what is blue baby syndrome, what is gray baby syndrome, what is pink baby syndrome. We discussed shortly in brief. The further discussion will be based upon the each and every topic, blue baby syndrome, how to approach, gray baby syndrome, how to approach, pink baby syndrome in detail. On each subsequent classes, we will be discussing in detail. So for today's session, so these are the topic I wanted to share. So we had a hopefully everyone understood. If any doubt in knowing about this topic, you are free to ask in the group or you can personally message me. That's not an issue. So by this, I hand over to Raghunandan for the end.
Thank you, sir. Thank you so much. It was a wonderful session once again. And we are hopeful that we will be having subsequent classes on every week. Uh, Students, if you have any doubt or any queries, you can very well share in the group. As well as if you have any doubts, you can post it in the YouTube comments too. And yeah, kindly share this among your batchmates if you find it interesting. And also attend the subsequent classes so that you will get a continuity. Thank you once again, sir, for joining with us today.
Okay, okay. Thank you so much.
Thanks, Nayan Pantana.
Okay, okay.
Okay, na. Bye now.